Hello, I would like to welcome everyone to IBM Watson Health Executive Webinar Series. Today's presentation is titled True Patient-Centered Care, Integrating Behavioral Health in PCMH Practice, presented by Charles Coleman, PHM Solutions Lead, Behavioral and Mental Health Programs at IBM Watson Health. Before we begin, I would like to review a few housekeeping items. First, you have Control Panel on the right side of your screen. You can minimize and expand this panel by clicking on the arrow in the upper right corner. Second, you can submit questions using the question panel located near the bottom of your screen. We will try to answer as many questions as we can at the end of the presentation. Finally, all registrants will receive a copy of this presentation and a link to the recording within 2 business days after the presentation. The information will be sent to the email in which you registered for this event. At this time, I would like to turn it over to Karen Handmaker, VP of Population Health Strategies at IBM Watson Health. She will introduce today's presenter. Thanks.
Thank you, Sean. This is Karen Handmaker, and welcome everybody to the webinar. I'm delighted to introduce Charles Coleman, who, as Sean said, is IBM's Global Healthcare Division's Population Health Portfolio Lead, and he specializes in cognitive computing initiatives in clinical quality outcomes, clinical research, and biomedical informatics and analytics. He is focused primarily on developing behavioral health and mental health applications at the point of integration of clinical, social, and genetic data. His expertise in behavioral and mental health stems from his PhD work at SUNY Binghamton, his distinguished dissertation on combat-related post-traumatic stress among Vietnam War veterans, and subsequent published work gained Charles international recognition for describing what would become the diagnosis of post-traumatic stress disorder. Charles has deep experience in health IT and a passion for quantifying quality to demonstrate clinical outcomes. He also is an adjunct assistant professor of health policy and management at the Gilling School of Global Public Health at the School of Public Health at the University of North Carolina at Chapel Hill, and is a member of a wide range of boards and organizations in his field. We are very pleased to have Charles present our webinar today on the rewards of integrating behavioral health and mental health into primary care and PCMH 2.0. And when Charles is finished presenting, I will be pleased to moderate the list of questions that I'm sure you will have. Charles?
Thank you, Karen, and thank you, Sean, very much. And it's a pleasure to be here today, everyone, and I look forward to our discussion. This is a very, very lively subject, as you know, and literally it's an aspect of healthcare that literally changes every day, and we'll see why that's happening. Today in part 1, we're going to talk a little bit about the what and the why of behavioral health integrated into population health at the primary care level within the patient-centered medical home construct. In part 2, which we're coming up in a month or so, we'll be discussing the how and the who. How do you integrate behavioral health into your population health management applications? And examples of who is actually implementing these holistic solutions into their care management workflows. And also the early outcomes of how well things are going in terms of this integration. So keep your eyes open for part 2. Within IBM, we often talk about population health and population health management in the same sentence. And we see behavioral health and mental health and substance abuse as components or subsets to our population health management strategy and platform. We also look at population health as being comprised of what I've come to call the 5 Ps. Number 1, policy and compliance. Number 2, practices, best practices, both clinical and in behavioral and mental health. Programs, ranging all the way from general wellness programs to very specific outreach programs for diabetics or for congestive heart failure folks. Process and technology, including workflows, and payment reform and value-based models. We're also integrating high-end analytics and advanced cognitive computing as we go along. And you'll see that as this presentation plays out along this sort of holistic integration that we're going to be talking about now. Because population health is really an attempt to work with the entire person and not just a piece and a part. And our strategy is basically to try to connect as many of the points of data around this compass based on kind of their logical home. So we've got plenty of clinical data coming in. We just now started with genomics. Typical of IBM, as you would expect, it's a very interesting area for research. And we're seeing it popularized today in things like the DNA analysis like 23andMe or even Ancestry DNA. And then social, family, and environment, we're talking about all sorts of environmental issues here. Think air, water, earth pollution. Think social and environmental determinants. Think the Zika virus, if you will, in the Summer Olympics. These are all environmentally related issues that fall under the heading of public health. But today we're going to talk about behavioral health, and that's what the subject matter is here. But these all are interconnected, and there are interrelationships that we're going to be looking at, particularly on the, excuse me here, yes, there we go. Yeah. We're going to be particularly looking at the causal relationships between clinical care and mental health and behavioral health. So the overview of the problem, we're going to look at disorders, diseases, and dollars. A couple of quick facts, and I'm not going to read all these slides. You'll have them at the end of the presentation, as Sean has indicated. But it's a huge problem, and there's not a day that goes by that we don't encounter some reference to mental health or behavioral health in the CNN or on USA Today or virtually everywhere. There's issues around mental health, PTSD, et cetera, that keep coming back, and it finally made sort of a debut, if you will, in terms of the correlation between chronic care and mental health and behavioral health. For example, a quarter of all cancer patients suffer from depression, and depressive disorders affect 15 million American adults at the cost. And we've also talked about the risk factors of untreated and undiagnosed depression post-heart attack. So some of the facts about behavioral health that we need to keep in mind are these general ones, but they're also very important in terms of the numbers affected. Take a look at 29% of all patients with chronic illnesses also have a mental illness. 80% of all mental health drug prescriptions are written not by psychiatrists or psychologists. They're written by, not by psychiatrists, they're written by primary care physicians and family doctors. And the majority of Americans receive their mental health care through their PCP and their family doctor. So this all points to primary care and the patient-centered medical home, which is why this discussion about the patient-centered medical home is so relevant. A quick takeaway, 29% of adults with medical conditions also have mental health conditions, and over 2/3 of adults with mental health conditions also have a medical condition. So you can see the causal relationship, the relationship between the mind and the body here is depicted in this slide. And this is going to be a pervasive theme through our discussion today. But it also has a huge impact on cost. These are the 5 primary disorders that we'll be talking about today. And you'll see that the green indicates no mental illness and no drug and alcohol abuse. But the blue, dark blue, this is undiagnosed and untreated mental illness and drug and alcohol abuse. You can see very easily the cost variations here between these two. And this presses the point homeward of the extraordinary amount of money that we pay for by not having treated or diagnosed mental illnesses and drug and alcohol abuse. We get into the risk factors here, and they're laid out, and again, I'm not going to read them all. But you can see the risk factors are up somewhere between 2 and 8 times. So figure average between 4 and 5x risk factor for these illnesses on the left-hand side. These are all documented. The studies are all completed. This is not a mystery anymore. Everybody knows about it, but how are we going to deal with it has been the question. So as the knowledge base is built around the correlation and the integration between these, it's also prompted a great deal of discussion about how are we going to deal with it in terms of treatments. For example, in this particular case, we're looking at diabetes with and without mental health and substance abuse, and you can see what happens on the relative risk factor when you add mental health and substance abuse to hospitalizations for diabetes. We see the same thing happening in COPD, asthma, pneumonia, bronchitis, same exact relative risk factors that come into play. Again, very dramatic. So some of the studies that we've investigated have shown that by intervening and attacking these problems head-on through outpatient mental health clinics, through screening, assessments, and so on and so forth, we can actually drive down the costs associated with care that create a fairly significant savings across the board by actually intervening and assessing the problems and treating the patients with these various mental illnesses and problems. Also, we can look at the chronic conditions and comorbid psychological disorders related to cost, and you can see how much higher they are per comorbid member based upon depression and anxiety. So we also know, because there's been a lot of attention focused on 30-day readmissions, we know that the risk of readmission increases fairly drastically with depressive symptoms of post-discharge. So all of this ties together into one construct that we're now aware of, and that's that these factors do affect each other in very dramatic ways in terms of quality of life, the quality of care, and cost. And additionally, as we discussed before, people who are most likely to be readmitted, the number 2 reason is for behavioral health. The number 5th reason is for alcohol and substance abuse. Now, heretofore, very, very few discharged patients are actually screened for a mental health disorder before they leave the hospital, which makes total sense because when they come back, usually the mental health issue is paramount or more aggravated, and then they can actually look to see what other conditions that are causing this bounce-back phenomenon. But again, this is fairly new. The thought of screening people coming in to a hospital or screening people when they leave a hospital for mental health disorders, depression, anxiety, bipolar, PTSD, is very rare. But it's becoming more popularized, I think, because people can now see the correlative value. Also, the cost. This just came out, for those of you who've been following health affairs and their publications. This came out a couple weeks ago, and it's the latest study that shows how mental health disorders top the list of the most costly conditions. And it's a comparative analysis here that has been prepared for us, and you can see how they've broken up the populations against various types of diseases and disorders and so on and so forth on the left column. But what they've looked at is civilian, non-institutionalized, and institutionalized and active duty military. And you can see that the mental health disorders far and away exceed over $200 billion for this particular population. And that is a huge amount of spending that we need to correlate and tie back to active plans. So let's take a look at some of the latest changes in care delivery models and delivery systems. This is kind of the old model, and I think we all are familiar with this. We've seen it 100 times. This is the fee-for-service with the doctor at the center of the universe, and all of the other aspects coming in from outside to bear upon his or her particular specialty. We've moved away from that in many cases, or we're trying to, and what we're seeing now, obviously, is the emergence of a patient-centered medical home with the primary care physician also running the patient-centered medical home, but you can see all of the various new players that have come in from behavioral health on the right-hand side, acute mental health complaints being addressed as well, point of testing, medical specialists. Over on the left, you can see the RN case managers with chronic disease monitoring, test results, and so on and so forth. And what's in the middle now is not only the patient or the member or the citizen or the person, but his or her family. So we're starting to treat our folks much more holistically with a much greater array of services around them in the patient-centered medical home construct. Well, Karen, I'd like for you, if you wouldn't mind, to take us through the next 2 slides. And Karen Handmaker is going to talk a little bit about how this plays out from a behavioral health integration strategy within the patient-centered medical home.
Thanks, Charles. I'm happy to. Just so everyone on the call is aware, Watson Health and our FITEL organization supports and is actively involved with the patient-centered medical home model, and our products support auto credit in many cases. So we have a lot of expertise in helping our clients apply technology to support behavioral health integration as well as other aspects of the patient-centered medical home. And this slide depicts the 2014 standards in a way that might help you see the cascade across the standards for how a high-performing patient-centered medical home would actually integrate behavioral health, mental health, and physical health the way Charles is describing. And it starts with, in Standard 2, with the notion of team-based care, ensuring that it either has co-located or referrals established with behavioral health providers and services. Then we talk about, this is the patient-centric aspect of it, making sure that we assess every patient and the entire population for behavioral health issues. This could be done by routinely using various tools to screen for behavioral health. It also is part of the intake process. It's also part of any care planning, which leads me to the next point about engagement in Standard 3, which asks care teams to make sure that they remind people about making sure that they keep up with their care plans and see their providers as appropriate, not just for their physical health conditions, but for their behavioral health conditions as well. And then the care management and support aspect comes in with Standard 4. And in Standard 5, which is something that Charles talked about earlier, with regard to coordinating and tracking referrals, if we don't do that and make sure that we close the loop on those referrals, then that standard is hard to uphold and something that is critical to managing patients with comorbid conditions, including behavioral and mental health. And then in order to make sure we're doing this right, as everyone knows, a big aspect of being a patient-centered medical home is the notion of having the capability to continuously improve, and being able to measure and evaluate and take action and then remeasure is very important. So all of these steps lead into how you can integrate behavioral health, mental health with physical health and fit these aspects into the workflows of a high-performing practice. Next slide. And this slide is something that many of you may have seen in one form or another, but the idea is that in order to make the patient-centered medical home workflows, for example, work together, it's critical to have the right people in the right roles with the right training. It's important to have the process designed appropriately, largely or often using Lean Six Sigma type of processes. And then technology is something that's not just put on top of a workflow, but literally designed in, and it continuously takes the leadership, a culture that supports optimizing the patient-centered medical home model and population health management, and working from the bottom up to ensure that the processes that we are driving towards will ultimately accomplish what we set out to do as we're describing. So Charles, I'm going to turn it back over to you, and you can pick up on these themes as you go forward. Thanks.
Great, Karen. Thank you. That was perfect. And in fact, I'm going to pick up on just exactly where Karen left off, and that is to take a look at what the current patient-centered medical home would look like for, let's say, collaborative care for diabetes. And this is a construct that I borrowed from Unziger that shows how the patient-centered medical home has evolved, in this particular case around a diabetic patient. So you can see the consulting endocrinologist is on staff, maybe virtually or maybe in present. You've got a diabetes care manager, which is coordinating the care, as Karen indicated. It's all under the heading of a general medical practitioner. And there are engagement programs and an administrator that manages that. For example, how do you engage people or patients into your programs? Do you do outreach? Do you do risk stratification? How do you keep them from fitting out? How do you keep them as members actively participating in their own care? And also being able to refer them to other community-based resources. And that model works fine, and it's in practice today, as we all know. If we were to add the same sort of thing for mental or behavioral health, it would look something like this. The same general construct. The area that changes the most is the bottom left, where you've got substance treatment, vocational rehabilitation, mental health clinics, and other community resources. But the operative role and the way it functions is pretty much the same. But what we've done here is we've done exactly what we've been doing all along. We've now got two tracks, two siloed approaches to the same patient, who, in this particular case, might be a type 2 diabetic with depression and bipolar disorders. So now the construct changes, and the patient-centered medical home, which we're calling 2.0, which is integrated behavioral and primary care for managing chronic disease and mental health disorders in sync, together, so that the healthcare coach now is actually managing that particular individual on a one-to-one basis, but a one-to-one basis based upon that individual's problems. In this particular case, we've identified a type 2 diabetic with depression and bipolar disorders. So that healthcare coach is going to be functioning on two levels simultaneously, and therefore the backup roles from the consulting endocrinologist and psychiatrist are going to be there to help assist the care coaches in their outreach and their management. And you can see also that the lower left-hand corner has changed too. Yes, we've got substance and treatment centers, we've got clinics for rehabilitation, but we've added home health care agencies and state agencies that would be comparable for mental health, for example, for the Department of Health and Human Services. So this is the new evolving role in construct that you can see, and as Karen indicated, it's a whole new construct because people are now having to work much more closely together in a coordinated way than they ever had before. And as you add more patients with more problems or more issues, you're going to see that the healthcare coaches are going to have to be trained in various areas to be able to more effectively reach and treat these people. So this is a whole new area, and you're seeing also, at least we're seeing in the academic side, care coach programs now at the graduate level and at the levels where integrated care is being sort of driven. We're seeing it in population health courses, we're seeing it in care coaches, and the PAs are now being educated to function in a setting that is much more conducive to coordinating care among the deliverers of care. So that's probably one of the more important aspects of how this is forming into a new day for integrated care. So I want to jump now to the risk stratification and assessments and some diagnostic tools, just so to give you an overview of what we're looking at and how we're trying to integrate these into our population health management strategy. So this is some IBM data that is from an actual client provider. And you can see listed on from 1 through 5 on the left the selected conditions that we have. And then 6, 7, 8, 9 you can see are the number of folks that have depression, anxiety, bipolar, or PTSD. And of the total number of chronic cases, which is 1,900, about 350 of those patients we found were diagnosed with a mental health disorder. So this is by simply going through, obviously, the provider databases of particular cohorts that we identified in this selection. But the interesting thing about this is that, yes, we're able to identify them based upon data in the EMR and elsewhere. But we find that 18% of the population has comorbidities that include one or more diagnosed mental illnesses. But what we don't know is how many of this population remain undiagnosed. And that is the whole point, I think, of why we need to integrate mental health and behavioral health, drug addiction, et cetera, much more closely into how we look at patients that we're trying to manage. And the only way that we're going to know how many remain undiagnosed, obviously, is to screen. We can screen at any point in the continuum of care, but obviously it's going to be much more effective to screen at the front end and then maybe do monitoring as we go along to see if we're actually controlling or containing or even preventing advances in mental health disorders or illnesses. So this we can do today, but it's only a piece of the puzzle, obviously, but an important piece. We can actually find these folks. And then obviously we can develop population health management programs to go out and reach out to them and be able to bring them into a cohort-based care coordination effort. I want to talk for a minute about how our similarity analytics work. So basically, we take a look at patients that we bring into cohorts based upon their personalized profile. And so we're looking for the most similar patients so that we can build a dynamic cohort. And the reason for the dynamic cohort is so that we can look historically in the rearview mirror, if you will, at populations and how diseases progress and how well they're controlled or managed. And so our patient similarity analytics take a look at which of those factors are the most important, which are the ones that we need to weight the most out of all the many inputs that we might get from our compass that we saw in the very beginning, all those points along the compass, our data sources, some data sources that we don't even know we have yet because we haven't actually gone and looked for them. But the ability then, based upon this selection criteria, is to be able to predict the probability of a desired outcome. So the patient, as you can see in the lower slide bar, is standing right in the middle at the moment. And we've got the historical data, the cohort, which is the longitudinal data with outcomes. So we have a knowledge of what's worked or hasn't worked in the past. And then we match that patient to similar patients in our database, our historical database, that look as closely as possible as the same patient that I have under my care right now. And we match them and look at how closely we can find parallel structures within our care coordination programs to be able to predict what's the best outcome for this patient based upon the data that I have, and therefore be able to affect far better care coordination programs, whether it's medication or whether it's referring to another specialist or whether it's a problem with nutrition or whatever. We can easily find those factors that are going to put this patient on a best desired outcomes path. We can do that too. We can do it in mental health by using some of the health diagnosing screens that are currently available. And I put up a few here. Many of you who are in this field are very familiar with these, except maybe for the last one. But the point here is that of the older tests, if you will, they tend to be more vertical. In other words, they're testing the PHQ-9, the Personal Health Questionnaire 9, is basically testing for depression. It doesn't look at any other aspects of the human mind from a mental health standpoint, or the anxiety test or the bipolar test. These are vertical tests. These are pinpointed and contained to look at specific mental illness or mental disorders. Only one, and it's a recent one, it's a new test which just came out a few years back, actually tests for all 4 disorders: anxiety, depression, bipolar, and PTSD. What's interesting about this slide is that the PHQ-9, for example, shows that it's missing 10 patients out of 25, and it's also showing how the aspects of the patient are not being fully addressed here, in the sense that depression, anxiety, bipolar, and PTSD don't come in one patient only. They come in varieties, mixes of mental illness and diseases that show us that, for example, there's a lot of overlap in anxiety, bipolar, depression, and even PTSD, which is technically an anxiety disorder. So this is a very good example of how we've advanced enough by virtue of these new tests coming out to be able to be much more selective and specific about what we're looking for and what we're finding. This makes it so much better, so much more efficient, so much easier in many respects to then be able to look at the patient as a mosaic of illnesses that we need to pay attention to, and not just diabetes, but diabetes with the mind attached to the body. In the mind of a diabetic, many of them are depressed. Some are anxious. Some have bipolar disorder. But you can apply the same thing to coronary diseases. You can apply it to asthma, COPD, the typical chronic diseases that we have such a burden of treatment and cost associated with it. So now we're able to really get very specific. We're moving more toward personalized medicine, more toward precision interventions to be able to control our populations and use these same tools to monitor their progress. So you might use a test in the beginning as a screening tool, but you could repetitively use the same test to monitor how well you're doing as a care coordinator and your patient's doing, or your individual that you're working with, how that person is doing along a continuum of care. So this is not a static snapshot, but a multiple of sequences of snapshots along that continuum of care. I know this is kind of a mess, but I put it up here because this is kind of how the sausage gets made, if you will. This is basically looking along the continuum of care, just like we saw before, but it's taking a look at a bunch of different variables that we're able to test for. Well, this is a mock-up. This is not taken from any current scientific-based study. This is one that I'm working on right now. I call it an ensemble model for prediction. Those of you who track hurricanes often hear references made to ensemble, whether it's the European model or the American model. Well, this is very similar, only I'm taking a bunch of feeds, data feeds. You can see a couple at the top there, hemoglobin A1C for diabetes. There's a mental health test score in the dotted red line, and so on and so forth. And you can also see what the progression that's happening here. This patient's kind of in a yo-yo state, kind of bouncing all over the place. But we're trying to get these multiple data feeds that are telling us about, obviously, about disorders and about other aspects of his or her condition. We're trying to get them into a weighted equation, a weighted band, using cognitive computing to level out these peaks and valleys and get them into more of a maintenance program whereby they can either control their problem or actually go into remission. And the descriptions here are really basically to show you how we're thinking about it in terms of a cognitive computing capability to be able to take many data feeds. It could be from remote monitoring devices. It could be from patient self-service studies. It could be from lab tests, obviously. It could be from the Fitbit, et cetera, et cetera. All of this data is coming in, and it's creating a huge problem in many respects because of the amount of data, and also which data is the most important, and which data is the most reliable, and which data is the most timely, and so on and so forth. But if you're using remote monitoring devices, and we are using more and more of those, of course, this all becomes very, very important. And we can actually now track many aspects of behavior almost in real time. And I think we'll see that happening more and more. Also virtual. We're seeing more virtual psychiatry, telepsychiatry coming up. We're also seeing more people being involved in group programs around identification of certain risks that they want to participate in care coordinated or care vetted programs that hospitals and sometimes the payers or sometimes the employee assistance programs provide. Let's take a quick look now at natural language processing in the unified data model, and I'll sum this up shortly. We're getting there. Using Watson Health content analytics, we can apply the NLP, the natural language processing tools, to unstructured data. And as many of you know, a great deal of medical clinical data is unstructured, particularly in psychiatry and psychology, or even in social workers, psychiatric social workers. Many of the stuff that is compiled there is in text form and is not in the structured environment. The NLP tools that are comprised of Watson Health Analytics actually can look through those data, those unstructured data components, and extract certain concepts, certain attributes of the information that can add tremendous value to the structured data. And it's a process whereby the output is then actually far more structured than what you're looking at right here. And the whole idea is to be able to upload various types of treatment codes and various types of new data in materials into a structured EHR. So it's a very valuable tool. It's very efficient, and it can be fine-tuned for specific diagnostic areas. The other part that is really critical to being able to advance population health and behavioral health and mental health is the unified data model. The unified data model for healthcare came out last September. It's a full-blown unified data model with pre-structured, predefined data structures that include behavioral health and mental health. I don't know of any other data model that I've seen before that includes behavioral health and mental health in a typical data model array, i.e. terms, content, analytical requirements, the data model itself, and the data warehouse models and the data marts. You can see down on the far right-hand side, we've got clinical patient history, mental health history, substance abuse history, criminal justice history, and socioeconomic history. These are all brand new in terms of being able to fill out that sort of the points of the compass that we saw when we opened the presentation. This is an ability to start to address these outliers of data that are so important to holistic coordinated care in a population health management program. And the unified data model also covers some substance abuse and some social determinants. And you can see here how the data model is basically set up and the new things that have been added. It updates the existing content in the data models that we had previously under care plan, care team, discharge episode of care, and risk assessment. So this gives us a structure to be able to start to manage the data, which is really what the UDMH is. It's a data management tool, data collection and staging tool that's put into a structure that is queryable and can match against many, many variables depending upon how you weight your query. Then out of that comes the new continuum of care documents, the so-called CCDs or CCDA, which is now including behavioral health. So this is all brand new in many respects, but the CCD has been added with the mappings into the IBM unified data model for healthcare. So we've got the content now, we've got structure, we've got the ability to pull in unstructured data into a structured format. And now we have it set up so that we can actually do operational queries and be able to build our patient cohorts and take a look at a longitudinal care plan that includes a lot of data that we've been able to collect based upon best practices. And this is a summary slide, so we'll be ending very quickly here, but I thought this was a good representation. I borrowed this from Kaiser, so thank you, Kaiser. And you can see how they've laid it out, and I think this is one of the ones that really typifies how we're seeing the care coordination, the care location, and the integrated care along the continuum. You can see it starts with screening and stratification, which is, we talked quite a bit about that, including patient similarity indexing. We talked about the care coaches, the navigators, using NLP in risk stratified cohorts to be able to provide integrated care plans. The co-location is critical because obviously folks go from clinic to hospital to home to nursing home to clinic to whatever, and those need to be connected, and they are connected in many cases, particularly in the large systems. Health homes, we talked about that, the evolution of the PCMH to include mental health and behavioral health, and also to be able to perform tests and include preventive interventions. And of course, the system level integration, we talked about that, being based on interoperability, semantic interoperability process, workflow interoperability, and also being able to analyze costs and outcomes in quality reporting, all in one construct. One of the first things that I mentioned was public policy, and I just want to touch on that briefly. Public policy payment reimbursement laws for mental health, behavioral health, and substance abuse, as we all know, are fairly lax in some respects. There's not a lot. There wasn't historically a lot of policy that drove reimbursement for mental health, behavioral health, and substance abuse issues historically. But that's all changed. We hear much more about it today. We're seeing all kinds of new laws coming about. In fact, there's probably not a day that goes by that something in Washington or something among the insurers is indicating more and more acceptance of being able to head off this problem, this pandemic of illnesses, mental health and behavioral and substance abuse issues. And one of the leaders in that whole charge is the Kennedy Forum. Many of you probably remember how the Kennedy Forum came about, but it's really Patrick driving the whole awareness of mental illness and substance abuse into the public domain. And they built their model on 5 pillars: payer accountability, provider accountability, integration, coordination, technology, and brain and health fitness. Now, the notion of accountability is really an issue around what they call health parity. So there are certain acts that have been, some very recent, by the way, within the last couple of weeks, that have come out to be able to balance the amount of attention and coverage being paid for clinical care versus mental health, substance abuse, and behavioral health. And these are a couple of the acts that you can see here. So when they talk about parity, they're talking about responsibility at the federal level to be able to manage and reimburse for various types of healthcare coverage that normally wasn't being covered. Or if it was being covered, the insurers weren't being accountable for that. They weren't reimbursing for many of the mental health and behavioral health aspects of care. But now you're seeing these changing, and this is all in part because of the huge toll that substance abuse, untreated, takes on our society and, in fact, the whole world. So these statistics are now coming forward in ways that, although they're alarming to us, we at least now have an opportunity or a chance to be able to integrate behavioral health and mental health care into our population health care management programs. We mentioned Pillar 3, which is integration and collaboration, which I've spent quite a bit of time on. And the Kennedy Forum has taken a very, very aggressive stance here on how to actually implement collaborative care that treats mental health and substance abuse. And it's team-based, population-based, patient-centered. There's measurement, there's evidence, there's practice, testing, and accountability. These are the constructs that we're following in terms of our relationship in building out population health management tools, applications, solutions, and products for people to be able to do this integration. Another one was that just recently came out was a so-called CPC Plus, which affects both payment and care delivery models. And you'll see at the bottom, in those practices will be expected to provide enhanced services within the 5 functions for patients and complex needs, including identification of psychosocial needs and resources and supports to meet those needs. Again, all new legislation, riding on the back of some of the older programs. They're being updated and enhanced now to include the mind with the body. The last pillar is one that we're particularly interested in, obviously, is technology, which how do you make all this happen? And I mentioned about best practices and evidence-based. I mentioned regulatory requirements, reimbursement, and the immediate public health issues. So this is a kind of a Bible. If those of you who are interested in pursuing this further, the Kennedy Forum is an excellent resource for seeing how this fits together and what the barriers to entry are, regulatory in particular, and how the legislature is moving through trying to address these issues. The last one I'm going to just mention here is the so-called PDP model, which is becoming much more prevalent and much more, I guess, advertised as a way to managing the total costs of care in identified populations. And of course, the TCLC, which has been around for a while, is another one. There's a whole litany of information at the legislative level and the practice level that I'd be happy to forward to anybody who's particularly interested. But I would suggest the first quick read of the Kennedy Forum data would be very practical and helpful. This is one of the newest ones released. This is the MACRA study. It came out in late April, and if you read it, it's very interesting. This is new. These are new rules, proposed new rules that are coming forward, which we've never seen before. So you can see that there's a lot of interest and a lot of enthusiasm here about being able to crack this nut and connect the dots among behavioral health services. And you can just read the 3 or 4 sub-paragraphs there: evidence-based treatment, evidence-based screening, regular communication, case reviews, use of a registry, which I talked a little bit about, and then integrated behavioral health within the medical care plans. And you can see the bottom one there is integrated behavioral mental health again. This is the enhancements to the electronic medical record to capture data, behavioral health data, and use it in decision making. So that's a snapshot of what I started off discussing with you today. I hope this was helpful. And again, this is part 1, which is the what and the why, and part 2 is the how and the who. And this is my friend here. I'm a member of the Warrior Canine Connections and have been for quite a while, and they train, they breed, train, and link up dogs with returning veterans in a kind of a therapeutic mode. And it's a very creative program. It's had huge success with mostly from veterans that are either disabled or suffering from PTSD or TBI or all 3. So I guess that brings us to questions. Karen, are you going to?
I am. Charles, this was excellent. Very, very helpful, and we have some good questions. I do want to start, though, by amplifying a little bit about what you said at the very end about MACRA. The snapshots that you showed in your slide for everyone who hasn't delved into the 900 pages of proposed rules. These are snapshots of what the program is calling clinical practice improvement activities. These are things that Medicare fee-for-service providers will need to demonstrate that they are doing in some combination with other activities in order to maximize their score that will be used to adjust their the Medicare fee-for-service payment schedule. So these are in addition to the quality measures that will be incorporated into the calculation of the score that individual providers will get and what they will receive in terms of payment. So the point of bringing this up and highlighting it is that this is going to have a dramatic effect, we believe, on practices and individual providers, and drive the behavior that is going to be so essential to driving the integration of behavioral health and physical health, which is clearly necessary from the case that Charles presented in order to improve outcomes for individuals. And I'm sure that many of us either treat or know people who whose care would be tremendously improved by these integrated efforts. So something to keep in mind, and a topic that we can talk more about in part 2 that Charles referenced. So one of the questions that has come up is it's really good and really important that when you go to the doctor that there'll be much more attention paid to individuals holistically, considering their behavioral and mental health issues. But how are we going to help patients people with these issues for all the hours and days and months that they are not in front of a practitioner, be it a clinical doctor or a behavioral health specialist. What tools and processes will be available to support individuals in between, as we say? Any comment on that, Charles?
Sure, Karen, that's a great question. And there's the evolution of the self-monitoring tools have become very popularized, all the way from passive Fitbit tools all the way to proactive engagement tools, such as some of the ones that have the screening and assessment capabilities on an iPhone, for example. There are applications out there that you can do self-monitoring, or you can actually monitor and screen yourself at various points in time and have that data then uploaded into a file for your case manager or your caseworker or your care coach to look at and incorporate that into the continuum of care. That's all out there. We're going to see a proliferation of it. I think many of the tools that are specific to mental health and behavioral health are going to have incredible value over some of the more popularized versions, I guess, of monitoring your health. So they're out there. They are tied to certain databases. Some of them actually even have a pathway into the EMR by virtue of it being a lab test. So it's a way to reach virtually anybody and everybody that has an iPhone.
Thank you, Charles. That's very helpful. One question, and this is probably going to be a preview to part 2, but are the screening tools that you mentioned likely to be integrated into the major EHRs, or will they have to be interfaced and integrated from other systems for a long time to come?
That's a great question. It's
a great question. Yeah.
Yes. I think in time we will see the EMRs move more and more toward behavioral health, perhaps, or certain population health. Getting down into the specifics of what we just presented here today, I don't see that showing up in a prepackaged EMR for quite a while. So I think the issue here is going to be integration. How do I get this data into the EMR? And we are actually doing that today. IBM is actually working on a number of projects where mental health and behavioral health data is actually being integrated into the EHRs. So that is going to be the place. Now, that's not the only place the data can go. Obviously, care coaches are going to be working off of care coordination platforms and solutions. That's an extraction out of the EHR, EMR. And those are, of course, many of the tools that we at IBM have to be able to stage the data and derive value from it from an outreach and a treatment protocol-based plan.
Yep. Well, we just have a couple minutes left, and there's a couple categories of questions. Charles, people have been weighing in with their own efforts to integrate behavioral and clinical health inside the primary care practice, and have a lot of interest in the diagrams and the models that you've described. Is there any emerging model, or is this going to be happening for a long time as we see physical health integrated into mental health and behavioral health settings and vice versa?
I guess the question is, how close are we to being able to see an integrated model between clinical and...
Yep. That's a better way to put it.
There are certainly pilots out there that are being done right now. Some of them are at, I've seen at UCLA. There are some at Yale New Haven. There's some at the University of Virginia. For example, Cleveland Clinic is working on a very tightly integrated program right now that IBM is participating in. So yes, the answer to your question is I think we're going to see it before the end of this year, the end of this calendar year. We will have models that providers and payers and EAPs and so on will have created on a pilot basis, and I think 2 or 3 of the best pilots will ultimately coalesce into what we're going to describe as our final sort of entree into population health, integrated population health at the PCM. Level.
That's great, Charles. And then I just want to close, because we are at the top of the hour, by acknowledging that there's lots of questions and comments. Looking forward to part 2, where we will be talking about the tools and solutions that IBM Watson Health can offer, and various tools that are available to support the integration from a technology perspective for behavioral and physical health. So with that, thank you very, very much, and thanks to everybody who attended. And Sean, did you have any closing comments?
Yeah, all I wanted to let everyone know is that you will receive a follow-up email that includes this presentation and a link to the recording within 2 business days via email. And we also ask that you take the brief survey when you log off the webinar to help us learn more about what was effective and how we can improve on our future webinars. At this time, the webcast has ended, and we thank you so much for attending and hope you have a wonderful day.